Thank you very much. Is that on? Yeah. Thank you. It's really a pleasure and an honor to be here. I don't know if you realize it, but on this monitor up here, while you guys are looking at me, I can watch the game. So if I seem distracted, that'll be the reason. So this will be a rather basic, I think, overview for many of you, but it's just probably a little bit of more value to the newcomers in the audience. So I'm going to talk about a brief update of available treatments and where things stand in the year 2014. So before I talk about specific drugs, I'm going to say, first of all, this is going to focus on chronic phase CML. Now, I understand there are parts of the world where, unfortunately, more people are diagnosed in the more advanced phases, but I think it's still the case that probably on the whole, more people are diagnosed in the chronic phase around the world than in more advanced phases. And so if we think about goals of therapy for the chronic phase group of patients, I think number one, of course, we would like to, above all else, prevent the disease from transforming to accelerated or blast crisis to the more advanced phases. And the reason is because chronic phase CML in that phase is not immediately life-threatening. So it's highly unusual for people to die even of untreated CML in the chronic phase. The issue is, of course, that as the disease transforms, it becomes more aggressive, and then that becomes much more life-threatening. So if we were able to just prevent this, then patients would, of course, be what we call functionally cured. And the way that I sometimes convey this issue to patients is to remind them that it's a little bit like the treatment of high blood pressure, where the treatment doesn't eradicate the high blood pressure, it controls it, and it prevents the complications. But this will, of course, if this is the goal only, this would almost certainly require lifelong therapy. And as with anti-hypertension medications, chronically administered therapies really need to be very tolerable, ideally, and minimally intrusive to normal everyday life. Now, of course, the ultimate goal is true disease cure, meaning by this definition that patients may be able to stop therapy and never have their disease come back. And of course, since people with CML may be diagnosed in even the pediatric age range, they may have 60 years of life left ahead of them. And so it's going to be many, many, many years before we have confidence that such young people could be potentially cured by something like TKIs, for instance. But what we do know about in terms of known curative therapies, of course, allogeneic stem cell transplantation. This disease was once the prized disease for treatment with allogeneic stem cell transplantation. We know it has about a 70% rate of cure, but there are some problems with it. Of course, there's about a 20% risk of mortality within the first year or two with this procedure, and this is typically due to the procedure itself, to toxicities due to the procedure, and not due to the disease. And in addition, of course, amongst those who are cured, a substantial proportion are dealing with some type of ongoing toxicity, graft versus host disease. And then, of course, it bears mention that this was only an option for a very small proportion of patients, either because they were not young enough to have the transplant, or because they had other comorbid conditions, or because there was no effective matched donor. So this has been used less and less and less in the management of chronic myeloid leukemia. So interferon alpha is another agent that I link it up here. I put it up here in the True Disease Cure. I think it may be a little bit premature to say this, but interferon therapy by itself, or when combined with cytarabine, so this is not in addition to TKIs, this is just by itself. We know that there are patients who took interferon for a defined period of time, back in the late 1980s or early 1990s who've been off therapy for more than 20 years who remain without any evidence of disease. It's a very small proportion of patients, but because of this, 20 years, if we think of the disease and how long it may take the disease to go from the very first cell to where we see evidence of the disease, we know from the studies that were performed on atomic bomb survivors in Japan that the number of cases following 1945 increased, and it peaked somewhere between 6 and 10 years following the atomic bomb. And so our thought is that it may take that amount of time on average to go from having one disease cell to having detectable or to having clinically detectable disease. And so if you think about being more than 20 years out, I think it's reasonable to assume that patients may in fact be, a small proportion may in fact be cured by interferon alpha. But the problems, of course, with this drug, and the reason why we don't talk about it so much these days is because this was very difficult for patients to tolerate, and the benefit was restricted to a small proportion. There are longer acting preparations of this medication that may be better tolerated, and some of these have been investigated in CML and in polycythemia vera, but this drug for the moment has not gotten a lot of attention as treatment alone. It is being combined, as you probably have heard, with tyrosine kinase inhibitors, and I'm sure one of my colleagues will talk about that during the meeting. So I want to talk now and focus the rest of the talk primarily on the tyrosine kinase inhibitors and just give you updated, as up-to-date information essentially as I can. And first I'm going to start, of course, with imatinib, which, as you all know, was the very first tyrosine kinase inhibitor to be developed. Now, I have up here 7 to 8 year follow-up of newly diagnosed patients, and this is data from the so-called IRIS trial that was the first study to employ imatinib as therapy in newly diagnosed chronic phase patients. To the best of my knowledge, we will not have any more mature data than this, unfortunately, because it's my understanding that the drug company decided to stop continuation of the study, which I think is rather unfortunate because this was one of the first trials. It would be a nice way of knowing how long are people likely to do well. But so what we do have is shown here at 8 years, and what is very impressive, of course, is that the estimated overall survival is 85%. And if we think back to before this drug was available, the estimated length of time people would be expected to live in the absence of any effective therapy at all was about between 5 and 7 years. So after 8 years, we would have expected less than 50% of people to be alive if this drug had no activity. So 85% is certainly very encouraging, and even more encouraging if you look at the red curve is if you remove those deaths that are unrelated to CML, then you can see that a very small proportion, 7% of people after 8 years have died due to their disease. Of course, we'd like to have that number go even lower and have virtually everybody alive after 8 years. And we'll talk about how the newer drugs may be getting a little bit closer to that, but there's still, of course, some room for improvement. But nonetheless, to put this into perspective and to think about how this looks compared with prior decades, this is a slide looking at the MD Anderson Cancer Institute or Cancer Center, and what you see in white is the disease, what we call disease-specific survival. So that means the likelihood of being alive and free of dying due to disease, in this case after about 8 or 9 years. You can see again, just like what I showed you in the previous slide from that IRIS study, you can see that 93% or so are expected to be in this disease-free survival group. And you see 84% again looking at all overall survival. But if you look at prior decades, the green shows you 1990 to 2000, substantially worse. So we are very confident that this drug is profoundly improving the survival in chronic phase CML patients. It is not a perfect drug. There is no perfect drug out there. There are some side effects, and what I'm trying to show you here is after 5 years, this is what has been reported in terms of what we call the adverse events on imatinib, and they're grouped into two categories. The first number you see, all gray, that means anything from mild and moderate to severe and life-threatening, whereas what you see on the right are only the severe and life-threatening adverse events. So the good news, if you first look at the right, is that there's a very low proportion of serious and life-threatening adverse events. They do occur, but again, it's a very low percentage. The not so good news, if you look at the column on the left, is that a lot of patients are dealing with some low-level toxicity. In many cases, this is on a chronic basis. So coming back to the issue of trying to, if this is a drug that people are going to have to take for years and years and maybe decades, we have to keep in mind the impact that it may be having on quality of life. We have learned, and you'll hear a little bit more probably from Professor Salio next, about treatment milestones that we want patients to achieve. I think within the most recent years, one of the more meaningful advances in this regard has been the value of testing of the BCR-ABL level by PCR as early as 3 months. Of course, the PCR test, as we all know, is very nice in the sense that it can be done on a blood sample. It doesn't require a bone marrow aspiration. I've never met a patient who was desirous of having a second bone marrow aspiration after having the first one. What you see here is there's been replicated in numerous studies, is actually overall survival is associated with having a BCR-ABL level of approximately 10% or less on the international scale. Now, this, of course, this issue of the international scale, we talked about a little bit in the morning in the 101 class that Pat led, but this is part of why we're trying to get labs around the world to adopt this so that we can employ this information confidently. And what you see is those patients in blue who get to that low level at 3 months, overall survival is significantly improved compared with those patients in orange who do not get there. Now, of course, there are no absolutes here, and the not so good news, as you can see, is that blue curve is coming down a little bit. So despite having that level of response, we can take certainly a deep breath and feel very confident that people on that curve are likely to do very well. But certainly we cannot be 100% certain, and it's critical to continue to monitor the disease. Similarly, if we look at the orange curve, even in those, if we want to take the other point of view and say that even those patients who don't get to that level of response, you can see that the survival rate is respectable. It's not as high as we would like to get, but it's not necessarily a sign of doom if patients do not achieve that. Nonetheless, this has become really a very important treatment milestone. And we know that approximately 65% of patients treated with imatinib will get to this milestone. So in terms of concluding where we stand today with imatinib, the 85% overall survival that's been observed after 8 years certainly exceeds what we would have expected if the drug did not have any significant activity. Now, at this moment, the most critical level of response, in my opinion, is complete cytogenetic response. This is the level of remission that is best correlated with longer-term outcomes. And so we know that 82% of patients who were treated on that IRIS study with imatinib at one point achieved that level of response. At the last analysis, however, only 55% of patients were remaining on drug, and nearly all of those that were remaining were in a complete cytogenetic response. And so despite having achieved a complete cytogenetic response, in some cases, patients may lose that, of course, or they may have tolerability issues that causes them to go to an alternative treatment. The responses achieved with imatinib are are, as we know, typically durable, and we've learned that the risk of a loss of response event generally decreases over time. It may be highest within the first 3 or 4 years after starting treatment, and that is why it is especially critical, we think, to monitor the disease carefully, especially during the first 3 or 4 years after starting therapy. While imatinib is generally well tolerated, there are a low grade of serious adverse events, but to the best of our knowledge, life-threatening toxicities are extremely uncommon with this. And over time, I think it's been rather reassuring that there have not been any new serious, potentially irreversible toxicities that may develop with this agent. And that's something we'll come back to maybe in one of the sessions tomorrow or the next day. So now to talk about the other 2 agents that in some parts of the world have also been approved and are available as first-line therapy. These are the first 2 second-generation kinase inhibitors to be approved in many parts of the world for frontline therapy. And I just wanted to summarize here the data of these 2 studies. The ENEST-ND study was the study comparing nilotinib with imatinib, and the Decision study was a similar study that was comparing dasatinib with imatinib, and these are in previously untreated chronic phase patients. And I don't normally like to put these types of studies side by side because I think it tends to encourage comparison, which is not really appropriate, because even though they were both compared with imatinib, they were done in different parts of the world, and response may have been evaluated slightly differently. So the important thing, though, is if we look at complete cytogenetic response by 12 months, you see for both the newer drugs, superiority compared with imatinib. Similarly, if you look at the second row there, the rate of achievement of that 10% or lower level by PCR by 3 months, again, you see superiority for both drugs relative to imatinib. A 3-log reduction, a major molecular response in the third row down. You can see, again, superiority for both drugs relative to imatinib. The 4.5 log reduction, which we are using as a criteria for some of the treatment discontinuation studies, is achieved at least by 4 years more commonly with the newer drugs compared with imatinib. And both drugs, as you can see in the last row, appear to be associated with a lower risk of disease transformation. And this is, even though those numbers are relatively small, 90% or so of those events are fatal. And so it is, I think, notable that these newer drugs appear to be associated with a lower risk. Now, those are all favorable features of the newer drugs, but again, as we'll start to discuss over the coming days, we've learned about some longer-term toxicities and in some cases potentially irreversible toxicities of these newer drugs that we do need to certainly keep in mind moving forward. So options after imatinib failure, of course, both dasatinib was the first drug approved for patients whose disease had progressed or were intolerant of imatinib, and nilotinib soon thereafter. And again, I don't put these up here to encourage comparison between them, but just to show you that by and large, these are in the same ballpark as is bosutinib in terms of the complete cytogenetic response rate in patients who can no longer take imatinib due to resistance or intolerance. Ponatinib is actually a very active drug, as you can see. It was actually used in patients who were probably the most heavily pretreated that you see here, including patients who have this one particular drug-resistant mutation known as the BCR-ABL T315I mutation that is resistant to all the other drugs you see listed here, but is sensitive to ponatinib. However, due to some side effect issues, again, coming back to serious and potentially irreversible side effects, we are not using ponatinib unless patients are essentially don't have any other TKI options. So coming briefly to side effects of TKIs, again, we're going to go into this in more detail in the coming days, but I think, as many people in this room know, there are certainly some very common side effects, and as you saw on that first slide with imatinib, so fatigue, gastrointestinal issues, these can occur with all of these drugs, and you see in the middle there, myelosuppression, meaning the blood counts going very low, sometimes liver function test abnormalities, electrolyte changes. Those are in common certainly to all of them, as well as gastrointestinal issues. But then what I've tried to do here is show you some that are either uniquely associated with a particular drug or are maybe more pronounced with a particular drug. So starting with imatinib, so fluid retention and muscle aches and so on, hypophosphatemia, and some of the gastrointestinal stuff appears to be more common with imatinib than the other drugs. Moving to the right, bosutinib is it has a very high incidence of diarrhea, especially within the first month or so, and rash as well. And you see dasatinib is pretty much the only drug that's associated with an appreciable risk of pleural effusion, and there's also a little bit of a risk of bleeding with it. And we've found out more recently that there are some rare cases, but cases nonetheless, of something called pulmonary arterial hypertension. And we'll again talk about that more in the coming days. Nilotinib, you see, is amongst its relatively unique features are pancreatitis, changes in the bilirubin, high blood sugar. Of course, the QT prolongation is something that's been known to us for a while. And then now more recently, the cardiovascular events. So this drug does appear to be associated with thrombotic events in a similar manner to ponatinib, although not nearly as frequent as what we seem to have observed with ponatinib. And ponatinib is also associated with a fair amount of skin toxicity. So there are some overlapping, but then there are some relatively unique issues with all of these drugs. Of course, there are patients who may tolerate one of these drugs better than all the others, and we cannot say that any one drug is better tolerated than all the others. In the end, it's nice to have the option to make these different choices available to patients, especially if we're thinking about trying to treat patients over a period of many years in an effort to maximize their quality of life while hopefully preserving a very deep remission. Just a brief word about non-TKIs. In the United States, there has been approved this agent, omacitaxine. It's been approved following failure of two previous TKIs. You see here the complete cytogenetic response, 10%, not so exciting. You saw what the other TKIs did in the imatinib-resistant setting. And you also see here the median duration of response. Again, this means basically on average the responses are lasting about a year or so. So again, not so, in my opinion, this is not a drug that I've actually prescribed to a patient yet, to be honest. I think there may be rare patients who can benefit from this, who don't have any other TKI options and who don't have transplant options. But as you can see, I think it's unfortunately it's a drug of relatively limited utility. And one drug that, of course, I alluded to earlier is interferon. And I just wanted to show you what the complete cytogenetic response rate has been approximately with interferon. Now, this is not in patients with resistance or intolerance to prior TKI therapy, but this is older data from before the TKIs were available. So about a 15% complete cytogenetic response rate. Again, we know that those responses can be extremely durable if they occur, but again, we're talking about only about 15% or so of patients. We do know, however, we do believe, as shown at the bottom, that this agent by itself we believe to be safe to give to women who are pregnant or desirous of becoming pregnant. It's a protein our own bodies make, but it's given in much higher doses. So to conclude, I think we can say that the TKIs are certainly effective and are generally well tolerated. Again, there are some serious irreversible toxicities associated with some of these agents that we're learning more about as time has gone on. Certainly, both nilotinib and dasatinib look superior to imatinib in terms of achieving deep responses, irrespective of what that response is, a complete cytogenetic response by 12 months or a deeper molecular response almost at any time that's been evaluated so far. And also, these drugs are associated with fewer disease transformation events, which is very encouraging. Bosutinib and ponatinib are certainly also effective treatment options in the second line and beyond settings. Bosutinib has probably we have the least experience with, in part because this was the last of the second generation drugs to be developed, and it does not do anything that dasatinib does not do, for instance, and it is also associated with a high rate of diarrhea. And so for all those reasons, we have relatively little experience. It's probably the least experience of all these with bosutinib. As I mentioned, some of these drugs are associated with serious and irreversible side effects. Interferon can be active in a proportion of patients. And then lastly, I think CML patients who are able to have access to advocacy groups, to people like you in this room, I think they can maximize their chances of having hopefully an optimal therapeutic outcome. So that concludes my talk, and I'd be happy to take any questions.
We have 4.5 minutes for questions. I have a German sitting next to me, so we have to stick to the timetable. Any questions? Yes.
Is there any study wherein on Gleevec, imatinib, if the response is 0.001%, 0.001, not percentage, 0.001, the BCR-ABL, then for almost 2 years, same response, 0.001. What should the medicine be continued, or is there any trial going on Gleevec?
So you're talking. So I assume that this is on the international scale.
Yes, I am saying,
okay.
as far as I don't know, but the report says as per international report.
Okay. So that would be deeper than a major molecular response, which is
0.001.
Yeah. So
for
this
continuous 2 years.
This is an almost undetectable, it sounds like, or a very deep molecular response from what you're describing. So I'm going to present some cases actually in the next couple of days, which may. It's, to the best of my knowledge, the short answer to your question is no. This 0.001. So that would be more than a 4.5 log reduction.
0.001.
Yeah. So if it's more than a 4.5 log reduction, then I think that would be eligible for a discontinuation study. Yeah.
No, but is there any trial? I'm saying on Gleevec. The response is on Gleevec, not on Tasigna. Because I heard of some trials on Tasigna after 2 years of 0.001.
Yeah. Well, those trials.
Not on Gleevec.
Those trials were actually first done in Gleevec-treated patients in France. To the best of my knowledge, maybe somebody in this room knows whether or not there are those types of studies ongoing in other parts of the world. But certainly in France, that was first done with Gleevec-treated patients who had a level.
What I heard was that it was 50-50 chance.
Yes. So meaning that and I think others are going to talk about this, so I don't want to maybe steal their thunder, but 50%, approximately, a little bit less than 50%, have remained undetectable 5 years later. The other 50 to 60% had loss of that deep molecular remission, but their levels uniformly went back down once they restarted their Gleevec. So it's not 50-50 in terms of alive or dead. It's just 50-50 of
remission or
or PCR detectable again.
Detectable. So if it is detectable, Can somebody start the Gleevec again? And will it
Yeah,
work?
so
Will it work?
the French have shown that it's gone back down, and then even some of those patients, it's gone back down to zeros, have tried discontinuing a second time. And again, I think some other people are going to talk about the STIM study here, so I don't want to go into too much detail about that. Yes.
Dr. Neil Shah, my question is about the mixed therapy of interferon alpha and imatinib or Tasigna, because in the paper in NEJM, the rate of response of imatinib plus interferon alpha is about 10% higher than imatinib alone. And do you think the mix of interferon alpha plus imatinib could be compared with the second generation TKI? I mean, if these two could be comparable, then for some low-income countries, maybe for the patient who don't get good response of imatinib, maybe this could be an alternative.
Yeah, that's an excellent question. So just to rephrase the question, largely out of France, a group found that if you combine imatinib with interferon, you get a doubling in the rate of a very deep, an undetectable BCR-ABL level by 24 months. And again, if that is going to be, if you're thinking pharmacoeconomically and you want to do what you can to maximize the chances that somebody can, as inexpensively as possible, perhaps get to a level where they can discontinue treatment, that holds some appeal. Of course, as I showed you, the second generation drugs achieve that, by themselves, a higher level than imatinib, and the tolerability of the second generation drugs alone is probably better than interferon plus imatinib. But in areas that you're describing where the prices are prohibitive for the second generation drugs, then I think that's a reasonable thing to consider pursuing.
Thank you, Dr. Shah. My question is about the side effects. Is there a study that shows the time when a side effect comes up after, say, taking ponatinib? And can a side effect be triggered by something else?
Yeah, great question. So the majority of side effects that people with CML on TKIs experience, the majority of those occur within the first year or 2 years. Having said that, there are some side effects, for instance, pleural effusion with dasatinib. The risk of having a pleural effusion continues as long as you're taking the dasatinib. It's not as though after 2 years you can feel like you will not have a pleural effusion if you continue for another 2 years, because the risk is still there. Same with ponatinib when it comes to the thrombotic events. Same with nilotinib when it comes to the thrombotic events. In terms of trying to prevent these, there's nothing we know of that can prevent pleural effusion. We do think with dasatinib, we do think that it's related to dose exposure, and so sometimes in older patients, for instance, I may personally use a lower dose to start those patients, which I hope will be associated with a lower risk of pleural effusion. With the thrombotic events, of course, one wonders if you treat with aspirin, will that lower the risk? I think that's a very important question that I hope studies will answer, but at this moment we don't have any information yet to say that we can do things like that to prevent that, or for instance hyperglycemia with nilotinib, things like that it's not been studied in terms of what you can do to prevent. There are certain things you can do to prevent, like the nausea with Gleevec, for instance. If you take it with a full meal and a glass of water, that's supposed to make the nausea a little bit better to tolerate. And you can try to prevent or treat diarrhea with bosutinib to try to for some of those things. So the answer to your question is yes and no. Some of these side effects we can try to prevent, but some so far we cannot.
Can any doctor recommend reducing the dose from 400 mg to say 300 mg for an 18-year-old boy, wherein the reading is 0.001, as I said, for 2 years. Can a doctor recommend reducing the dose from 400 to 300?
So the question is, in a patient with a very deep molecular response on imatinib, even a younger individual, is it safe to, or can one consider reducing the dose from 400 milligrams to 300 milligrams? We think 300 milligrams is still active. So I would say if there's some really problematic side effect on 400, and you don't have access to any other medication, then I would say it's reasonable to go to 300. Otherwise, if there's no compelling reason in an 18-year-old, I wouldn't myself just change for no good reason. Yeah, I would not, unless there's a side effect.